Good morning, everyone. On behalf of the National Academy of Social Insurance, it's my pleasure to welcome you all to this morning's discussion on promising policy innovations, how to make aging affordable for all. My name is Rebecca Vallis, and I have the privilege of serving as the Academy's Chief Executive Officer. There's a great deal that's happening and being debated in Washington right now that impacts today's and tomorrow's older adults in the U.S., from a debate over the future of Medicaid to sweeping cuts at a range of federal agencies, including those that administer critical programs like Social Security, Medicare, Medicaid, and lots more. And while many of the Academy's members, including some today as part of this conversation, are deeply entrenched in those debates, it's essential that we also hold space for the long-term vision of social insurance here in the United States, including building the systems needed to ensure aging with dignity and grace is affordable and accessible to all of us. And it's in that spirit that we were incredibly pleased to publish this report by Ben Veghte, former Academy staffer and Washington Cares Director in the state of Washington, which is the first look by an American researcher at the Dutch long-term care system. That report is available on the Academy's website, nasi.org, published just this morning, so hot off the presses. And it's going to be the subject and really the springboard of a conversation that you'll be hearing this morning about what the U.S. and policymakers here in the U.S. can learn from the Dutch system when it comes to the American long-term care system and beyond. I'm going to welcome today's moderator onto the virtual stage with me as I introduce him. We're pleased to have today's conversation facilitated and moderated by Mark Miller. He's a journalist and an author who's a nationally recognized expert on trends in retirement and aging. He's probably no stranger and probably needs no introduction to the Academy community because he has moderated many events for the Academy over the years. He is also a frequent podcaster and has a wonderful newsletter you should subscribe to if you don't already on these issues. And I'll also introduce Ben Veghte, the author of today's report, and you'll be hearing lots more in a moment from him. But as I mentioned, he's director of the Washington Cares Fund, which is the nation's first universal long-term care program in Washington state. He's also an MIT CoLab Mel King Community Fellow, a member of the Board of American Society on Aging, and as I mentioned, a former senior staff member at the National Academy of Social Insurance, where he led a great deal of the organization's policy work. So I'm thrilled to hand it over to Mark and Ben to open today's event, and then you'll also hear from a range of experts using this conversation and this report and Ben's research as really, as I mentioned, a springboard for thinking about the future of long-term care in the U.S. So with that, glad to have you write this report, Ben, pleased to publish it, and I'm pleased to hand things over to you, Mark, from here.
Thanks so much, Rebecca, and welcome to everybody to what I'm sure is going to be a really great conversation around person-centered aging and how we can make it affordable to everyone. And as Rebecca said, we're centering this conversation around Ben's new paper, and which looks at the lessons we might be able to learn from the experience of the Netherlands. So I want to start off by talking with Ben about the paper and some of the key findings, and then we're going to pivot to a conversation that includes Ben and three other really outstanding national experts in the caregiving space that I'm really honored to share the virtual stage with. Ben, let's start off with this. What made you decide to focus on the Dutch experience and the Dutch system? What is it about this that is useful for policymakers and advocates here in the U.S.?
Thank you, Mark, and thank you, Rebecca, for hosting this webinar and for publishing the paper. Glad to be with you today. The Dutch face the same fiscal and workforce constraints that we do in terms of trying to address the long-term care challenge. But the Dutch approach it from the opposite starting point. They have a generous, comprehensive program with universal coverage, whereas the United States approaches this, the age wave from the opposite starting point, with a lack of widespread access to affordable long-term care. The Dutch case reveals, however, that the U.S. will not be able to fully address the long-term care challenge through traditional long-term care alone. The Dutch determined that it was fiscally unsustainable to address the age wave by maintaining the universal comprehensive program they had. So they had to find efficiencies in their system to meet the need in a more cost-effective way. After all, long-term care is not an end in itself. It's a means to an end. And the end is person-centered aging. And we can do better via upstream interventions and finding alternatives to formal long-term care in order to achieve the goal of person-centered aging in a more cost-effective way. The Dutch have learned, in the United States, we're going to need to do this as well, that technologies such as video calls, remote care, automatic medication dispensers, and other innovations can deliver care more efficiently. So those kinds of things are going to be important. But even more important is finding support housing solutions for older adults. The Dutch invented something called reciprocal care clustered senior housing, which is an adaptation of the co-housing model, which started in Scandinavia and also exists in the United States. But this is a way of getting older adults to move into communities before they need long-term care so that they can look after one another, get anchored in the community socially, and as a result, age in a person-centered way while requiring less formal long-term care, which makes it less expensive. So these kinds of innovations that allow us to achieve the goal of aging with dignity and independence, but with a smaller fiscal footprint, are the kind of things that the Dutch have innovated that we can learn from.
Ben, I think a lot of the people on the call probably know what the phrase person-centered aging means, but maybe you could just give a very brief sort of, elevator speech definition of the term. What does it mean?
It means that the people who experiencing the need can direct their own care. It means that they have autonomy and controlling the decisions around their life trajectory, rather than having some set of program requirements or financial dictates drive it for them. For example, many people in America live in states where the only access to long-term care that's affordable is through Medicaid, and you have to be impoverished before you qualify. And then in some states, you might end up having to go to a nursing home, even though you don't need nursing home care, because the home care system isn't sufficiently robust. Similarly, lack of affordable housing is a barrier to being able to stay in your own home as you age, which is another component of person-centered aging. So person-centered aging means be able to choose how you age and how you receive care and support.
Okay, good. Thank you for that. Let's talk a little bit more about the role that universal coverage plays in the Dutch system and how might that play out here in the US, aside from the rather clear fact that everyone would have coverage in that situation.
Sure. It goes beyond as you mentioned, the obvious, which is that everyone's covered. Really, first of all, there's equity implications to universal coverage. First, for the most obvious one is for the people who need care. Right now in America, if you're wealthy, you have access to, you can afford private long-term care insurance, or you can self-insure, pay out of pocket. If you're poor or if you become impoverished, you can access Medicaid. But again, there you're subject to the requirements of the program. And as we know right now, that program is under threat. So in bad fiscal environments, that program could be under threat. But the missing middle, the broad middle class is unprotected. So right now we ration access to person-centered aging by income and assets. And the Netherlands and several other countries have shown that that's not necessary, that there is another way to do this. Secondly, for family caregivers, right now, if you have a loved one who needs care, like my mother and father both have needed long-term care, many people have to leave the workforce to provide that care. One study found that on average, people who do that lose $300,000 in lifetime earnings and retirement benefits. It was a MetLife study from about a decade ago, but numbers are probably higher today. In a system like the Netherlands, where everyone pays into a fund to fund access to long-term care, everyone bears the burden equally of providing for this risk. In a country that doesn't have a robust system like the United States, the burden is borne disproportionately by those kind souls who are willing to provide this care out of the goodness of their hearts, out of loyalty to their loved ones. And so what could be a burden shared equally falls disproportionately mostly on women and women of color, who often are already disadvantaged structurally in other ways. And it can lead to people being impoverished or in poor health in retirement because they bore that burden themselves. So that's another equity aspect. And the third equity aspect relates to care workers. If you don't have a public system that's paying for long-term care, then you're going to, universally, what you end up with is that a lot of people who don't have access to private insurance or Medicaid hire people through private pay and try to find often the cheapest person possible. And so they end up hiring people with substandard working conditions, low wages, poor working conditions. And again, that also has tremendous equity implications. So those are three big components. But beyond the equity implications, having everyone in society pay into a fund creates a political constituency for improving the system. It creates a supply side driver to create a better care infrastructure overall. We all know right now that our long-term care system is it's a mess. Many people end up going to nursing home even though they don't need nursing home care. Our nursing home stock is antiquated and overly institutional in long hallways and people not having a high quality of life in those institutions. Most people, there are great alternative models out there, like the greenhouse model, which is a household model of care where people live in smaller environments that feel more like home, in a more natural, organic environment where people can age in place in their own community, receive holistic home care. There's a lot of different models out there that would be a better version and more all of us would choose for ourselves as we age. But because there isn't purchasing power and constituency for improving the system as a whole in a coherent way, we don't see those changes taking place. So with universal coverage, with robust benefits, you could see consumers driving a reshaping of the care infrastructure through their demand, and that's something that you see in other countries. So those are some important ways in which, and there's one final point I would mention, which is the provider side. So if you have a universal program that's pumping money into the long-term care system, kind of like in Medicare into the healthcare system for seniors, which then if you want to start a business, you're incentivized to start a home care agency, for example, or to start a greenhouse model of dementia care. And those models, which are more humanistic, more person-centered, but right now there isn't a good ROI on those kinds of investments. But if you have a strong funding flow through a universal public long-term care program, you could see providers also taking more risks to innovate in more person-centered ways.
Yeah. And, just to underscore the point you made a minute ago about family caregiving, I think often people refer to it as care that's provided for free. But, the old saying, there's no free lunch, as you're pointing out, it is not free. It has this financial effect on those who leave the workforce to provide care. And then you talk about the lost wages, the lost ability to save, impacts your Social Security down the road because your earnings history is affected by that. And that all compounds out over the years. So when you say, well, $300,000 or whatever the average, it's actually when you get down the road and look at the compound effects on all the retirement security systems, it's profound. And so what you see, I think, is this kind of playing out across generations. It kind of reverberates down the line.
Absolutely.
Let's go back to the Netherlands. You talk in the paper about some major reforms to the Dutch system that occurred in 2015. Can you talk about those a little bit, but what are some of the lessons there for the US?
So they did a couple of sets of reforms. So the first was a series of measures to reduce nursing home utilization. From 2013 on, they basically rebalanced their system. They made it harder to qualify. Unless you had significant needs, you would not go into a nursing home, you would get home care. They have universal home care, so that was not a reduction in coverage, it was simply rebalancing of coverage towards the community. And then a couple of years ago, they actually froze all new nursing home capacity altogether. They now see nursing homes as part of the past and not part of the future of long-term care. And the ones that do remain are moving more towards a humanistic model of care. Second, in 2015, they had one big integrated system for institutional care, home care, and social care. And they have divided that up into three separate systems. So the reform was meant to make the program as a whole more efficient, lower the cost curve, bend the cost curve over the long term. So it shifted financial risk for home health care, including personal care, from the national government's big unified integrated program, which was called the EMEA. They shifted the home care part to the health insurance system, which is a nonprofit health insurance system. This decentralization of home health care, together with the decentralization of social care, de-standardized the provision of long-term care at home and paved the way for tailoring care more to individual needs and more holistic care. It also introduced some cost-saving efficiencies by leveraging the regulated competition or nonprofit competition among these health insurers where they compete on service and quality, and have saved costs in that regard. They also integrated thereby home health care with other health care, so that when people leave the hospital, for example, the home health care, the health insurer can help make it possible, pave the way for someone to come out of the hospital, go back into their own home, and have home care immediately in place, which is a problem we are often dealing with in the United States, where we struggle with that. Municipalities were also tasked with tailoring care to each individual's specific needs, rather than just giving every beneficiary the maximum benefit to which they are entitled. A key part of this is what they call the kitchen table conversation, where they go into the home, with a social worker comes to your home, asks you to bring your loved ones into the conversation, whether it's family members or chosen family or neighbors, whoever happens to be helping you, and have a holistic conversation about, what does Ben need? What are Ben's passions? What makes him happy? What brings him joy? Maybe I like to play bridge. So if that case, they would make sure I'm connected to some local bridge club in my community. Maybe I want to go to the senior center and do other activities. A holistic approach to aging in place, to support aging in place. So those are some of the reforms that were done in 2015, and they have helped bend the cost curve. And there were other things as well, which we can talk about later on today.
Okay. And the last question I want to ask you about before we switch over to bring in our panel is, let's talk a little bit about affordable housing for older adults and what you've learned in your research about the Dutch model for affordable housing, and what can we learn about that would play out here in the US.
So this is a really critical component of the Dutch model. Initially, when I began this research, I was looking at their long-term care system. And I studied it, thoroughly. I interviewed expert interviews, talked to residents, et cetera. And then I realized at some point that there's a missing piece of this, which is the housing piece. And that really is a big part of the secret of the success of the Dutch ability to support person-centered aging. So Dutch seniors are able to age in the community, not only because home health care is free at point of use, you pay for it over the course of your career by paying into the social insurance program, but also because the country has a strong social housing sector that makes affordable housing available to virtually anyone who needs it. Over 1/3 of Dutch seniors live in social housing, a majority in multi-dwelling buildings, including a small but rapidly increasing number of reciprocal care senior housing, as I mentioned before. And that's where people move into a community where they're still relatively healthy. Most of the people are still relatively healthy. Some of the people have dementia or are frail, but they try to keep a healthy balance between people who need support and people who are still doing well. And then the community, it creates a social dynamic in the community where they can look after one another. And they're finding that they need less formal long-term care, which is expensive, right? And which we have to reduce over the long term. If we're going to get to universal coverage in person-centered aging, we have to reduce the cost of that, or else we won't be able to afford universal coverage. And so this kind of a solution that which is rooted in housing is really important. And they were able to do that over the last 150 years, really. Right. But it could be replicated in the US. But what it started out with investors, philanthropic investors, investing to get maybe a 3% return where they could have gotten a 5% return otherwise. And the social housing organization keeps the difference and uses that to invest in building more housing stock. And then the government got involved in the early 20th century and invested further. And these social housing associations now house about 1/3 of Dutch seniors, and the average rent is about 650 euros a month for these people. So they have their housing, which is affordable, and then they get the home care free of charge at point of use because they paid for it during their career. So this is really a key, because in the United States, assisted living, costs around $5,000 a month, plus a lot of add-on costs. Independent living costs maybe $3,000 before you've paid for any care. And so the housing cost alone is a big part of that. And if we can address that problem, either through social impact bonds or other measures to help fund and partner with the private sector to get investment in housing, that would be really important. One key part of this in the Dutch model is that investments in social housing, which have certain advantages for the people who do it, the housing is then permanently affordable. It doesn't go back to being for profit after a period of time as it does in the United States with the low income housing tax credit. And so it becomes permanently part of the affordable housing stock. And that's how they've been able to build it up over time to a significant portion of the housing in the Netherlands. And so things like that, we really need to think systematically about how to invest more, either through the government or through partnership with the private sector, to make housing affordable, because that really is a key component of this.
Fascinating. I will, I'm sure we'll talk more about that as we get into it with the panel. And thank you for that, Ben. Before I introduce the panel, I wanted to also mention we are going to save some time towards the end of the webinar for questions from the audience, and you should feel free to add your questions to the Q&A box on the Zoom at any time during the meeting. As they occur to you, just go ahead and add those. Um, and at this point, I do want to introduce our panelists, our outstanding panelists, and invite them to start their video and audio feeds so we can get our conversation going. And I'll just give brief introductions of the panel. Uh, Narda Ipakchi is Vice President of Policy and Programs for the SCAN Foundation. And SCAN is a public charity focused on grant making and policy work to support underserved older adults' ability to age well with dignity in their homes and communities. And before joining the foundation, Narda served as the Senate Aging Committee's policy director for Medicare and Medicaid. And in that role, she advised the committee's chairman on key issues impacting older adults and people with disabilities, including nursing home policy. Nicole Jorwick is the Chief Program Officer for Caring Across Generations. This is a national organization of family caregivers, care workers, disabled people, and aging adults who are working to transform the way we provide care in the U.S. And Nicole previously served as Senior Director of Public Policy and Senior Executive Officer of State Advocacy at the ARC of the United States. She's also worked in senior policy roles at the Employment First Initiative in Illinois and at the Institute on Public Policy for People with Disabilities. And Nicole is an accomplished special education attorney. And finally, Howard Gluckman is joining us. Howard is a senior fellow at the Urban Institute, where he works with the Tax Policy Center and the program on retirement policy. And Howard's the author of the book, Caring for Our Parents, and he blogs for the Urban Brookings Tax Policy Center and for Forbes.com. And Howard has worked on many, many policy initiatives related to caregiving for older adults, far too numerous for me to list here. And just speaking from my own experience as a journalist covering retirement and aging, I can say with confidence that Howard's one of the most insightful writers and researchers in this space. I never miss what he has to say. Howard, I want to start with you, and maybe we could do some table setting about what the current state of play is in the United States on these issues. Sort of what's the big picture of long-term care, the culture around long-term care policy in the US, what might be possible, what have we tried that hasn't worked, and so on. And also maybe some comment on the relationship between federal and state policy. Is that enough of a question that I've just tossed you?
You got an hour? I could. Um, so the state of long-term care in the U.S., I think, in a word, is a mess. It's a overly generous to call it a long-term care system. It isn't really a system at all. And much of what Ben described in the Netherlands is precisely the opposite of what we have here. So there's no coordination of care between healthcare and long-term care, except in some very limited circumstances. There's no system to pay for long-term care, particularly for middle-income people. If you're rich, you can pay out of pocket. If you're poor, you get Medicaid. If you're in the middle, you got nothing. Um, we do have far too many people who are in nursing homes. I estimate 20% of those people who are long-stay nursing homes have no medical reason to be there. They're only there because Medicaid will pay for housing in nursing homes, but it won't pay for housing anywhere else. Um, it's an interesting thing. We talk in the United States incessantly about post-acute care. And I think one of the great lessons from the Netherlands is the real solution to this problem is what I like to call pre-acute care. How do you get to people before they have that acute episode, the fall or the UTI or some other, a tragic effect that lands them in the hospital, and now you got to figure out what happens. You've got to figure out what happens in the middle of a crisis. Usually the default is a nursing home, which is kind of the wrong place for many people. What if instead we thought about this as a preventive issue? How can we prevent those falls? How can we prevent those infections? How can we prevent the loneliness? And if we could do that, we could save a significant amount of money if what you care about is the money. but we also would provide such a better quality of life for older adults and for their family members. But that requires really turning the thinking in the United States on its head. Um, I'll just end with one last little bit of data, which always fascinates me. If you look at a graph of how much the United States spends on healthcare and how much it spends on long-term care, and then you look at every other developed country in the world and you do the same thing, what you discover is that all of the countries spend pretty much the same amount on both things. The difference is we spend vastly more on healthcare and vastly less on long-term care, and everyone else spends more on long-term care and vastly less on healthcare, and they get often better outcomes.
So when you talk about a preventive approach, what comes to mind for me when I hear that is, well, what are we doing at the local level? It seems like so much of what's needed would be systems at the local level doing a better job of paying attention to aging. It's so-called age-friendly communities. One of these phrases that gets tossed around so much, but probably isn't well defined. But what are your thoughts about that aspect of it? It's kind of what needs to happen in communities are all across the country as opposed to some sweeping federal or even state level policy.
Yeah, Mark, it has to happen, I think, in a number of levels. It has to happen with physicians, primary care physicians. There's a little program we can talk about later called the GUIDE program, which begins to do this just a little bit for people with dementia, but there's really nothing else. It could happen through managed care. Unfortunately, it too often doesn't, but in theory it could. And then, as you say, there are the community solutions. You know, age-friendly communities, too often, I think communities say, well, we did curb cuts, so now we're an age-friendly community. And it's got to be way more than that. Um, but there are also non-governmental solutions that I've been very interested in for a long time. For example, using faith communities, using neighborhoods. We have in the United States, senior villages that try to do some of this. It's a little bit like what Ben was talking about, but not necessarily doing it in a single building, maybe just doing it in a neighborhood where people can get together in an organized way and help one another. Now, the response to that often is, well, that's not going to keep somebody out of a nursing home. And the answer is, well, maybe it won't, but it will defer the time when they may need a nursing home, sometimes by years. And that's not a bad thing. And it also does help create this kind of sense of sort of community. It's an interesting thing we could talk about later, but um, you know, a place like the Netherlands has this very strong sense of social solidarity, and the United States doesn't really. We're rugged individualists. We're all John Wayne here, and how do you get people to work together to help one another out? There's some interesting models out there, but not enough of them. Um, Ultimately, though, it kind of does get down to what Ben's original research was about, which is once people start needing paid help, whether it's in a nursing home or an assisted living facility or at home, it costs money. And the reality is, the bottom line reality is, we don't have enough money in the system to pay for it. We have to get more money in the system. And you could do it through a welfare-based model like Medicaid, or you can do it through a social insurance model. I prefer the social insurance model.
And that obviously implies raising taxes to do it, which is politically pretty hard to do.
I remember when we first came out, we've had an organization called the Long-Term Care Financing Collaborative about 5 years ago, which Ben participated in. And we came up with what was basically the model for a public catastrophic program.
Hmm.
And I shopped it around the Hill, talked to a number of people. And I remember talking to a very influential senator who said to me, what a great idea. This is terrific. This is exactly what we need. But you know what? We're not going to raise taxes to pay for it. Not going to happen. So that's the hurdle I think we have to get over. I think there's a growing recognition, and Narda can talk about this, and Nicole can talk about this because they're on the Hill a lot. I think there's a growing recognition that there's a problem, and there's a growing sense of what we could do to fix the problem, but there's very little willingness to pay the money and a lack of understanding that if you don't pay for the social insurance program, you're going to pay for it anyway. You're going to pay for it through Medicaid. You're going to pay for it through those lost wages that you were talking about before, that the family caregivers are going to suffer. So it's pay me now or pay me later, but they're politicians and they would rather pay later.
Yeah.
Somebody else worry.
Mark,
Narda,
can I
why
add
don't we?
one?
Yeah, go ahead,
Can I add
Ben.
one more? real quick, just one thing to that, which is
Yeah.
that it makes a difference on who pays too. Through one of the great things about social insurance is that it's inherently person-centered, because if we're all paying in, we get to decide, we get to design the system because we're paying for it. We're paying for the system. We as consumers then, when we're consuming on the back end, get to design it. Would you rather, and when we're designing it, we have an incentive to be cost effective. That's how it works in the Netherlands. The incentives are aligned so that the public insurance programs and nonprofit health insurers are all sitting around a table doing multi-sector planning together to try to design a system that's both person-centered and less expensive, because it's in everyone's interest to have that. Now, if we don't do that, then you end up with private equity designing a long-term care system, or other investors who have a different set of incentives that are not necessarily geared towards person-centeredness and not necessarily geared towards lowering the cost of the system overall. So you can meet a lot of goals by having the right people be paying for this in the right way.
Yeah. So the social insurance, a sense of ownership and control. I used to feel like that was the situation. Maybe not so much the last few weeks, but we'll leave that for another day. Andarta, let me pivot to you and ask back to what Howard was saying a minute ago about what's your sense of how people on Capitol Hill look at this question at this moment?
Sure. And I think it goes even beyond Capitol Hill. And, I think
Hmm.
we're seeing that in general in some of our, terms of some of our political climate in general, and what is palatable and what's not. You know, what I've observed is that with all of these types of policy changes, we're not necessarily doing a really great job of demonstrating beyond the first order impacts, what those second order impacts, third order impacts are that benefit not just the individual who is potentially receiving the support of long-term care, but their families, their communities, their employers, all the folks and stakeholders that Howard was just alluding to. And I think, one of the things that Ben wrote about in the paper that is particularly salient for the moment in time that we're in is that we need to do a better job of communicating that these types of reforms are universally beneficial. We always go back, to things like the ADA, where we talk about all the changes to sidewalks, et cetera, and subsequently how much that ended up benefiting young families with children and other folks that what benefited from just more accessibility in their communities. So we need to do, I think, just a better job of conveying the benefits not only to a particular constituency, especially in this time that we're in, where the main argument for or against any major reform is someone wins and someone loses. So we really need to, I think, just get away from that mentality. And I think some of the things too that Ben was talking about, just in terms of um, things being more led by the community and with community engagement and with familial engagement, et cetera, and really getting to some of that person-centeredness enables us to look at people that would be recipients of these programs, not just as stagnant widgets that we're paying, a particular sum of money for, but as our own friends, neighbors, community, and that we would want for anyone that we care about in our lives. And that message to me just really does seem to be missing.
Yeah. And Nicole, from your perspective, have there been any legislative advances in the US in this area over the last few years?
Yeah, I mean the good news is while I agree that there's a lot of benefits to multiple solutions in this area, from making sure that we're modernizing Medicaid. Medicaid, I don't believe is the answer for everyone, but we can do a lot to address the burden on Medicaid while we're also building social insurance or other models. And there have been advances in that. One of the things in this, both Howard and Ben touched on this, but just to name really explicitly from polling that Caring Across Generations has done, we know that 95% of disabled people and 90% of older adults want to age in place and stay in their homes and communities. And there have been advances to make that more possible. But the reality is while there have been decades of investments in what we call rebalancing, there is no state where 95% of Medicaid dollars are going to home and community-based services. Someone just asked me on a podcast yesterday, if I had a magic wand, what would I do? That would be the first thing I would do, so that we could make sure that what we're investing in is what people actually want as they age or experience disability. And there have been advances in the American Rescue Plan Act. There was the largest investment of after state reinvestment, over $37 billion into strengthening and expanding access, strengthening the home and community-based service workforce, and providing more access to home and community-based services. It was short-term funding. It was for a year of funding, but all 50 states took it up. That just shows that when there is money available, which I agree with both Howard and Narda, that is a complicating factor. But when it is available, every state is taking it up because of the level of need and because that's where people want to be receiving their services. There's also been bipartisan support for the last 20 years of a program called Money Follows the Person, which allows Medicaid funding and allows a lot of flexibilities that Medicaid currently doesn't cover. As an example, and Howard mentioned this in his remarks, and so did Ben, that Medicaid doesn't cover room and board for home and community-based services, but obviously does when you're talking about a facility-based service setting. And so what Money Follows the Person allows is some flexibility, so you can use some of that funding, Medicaid money, to pay for the first and last month rent, which so often is the reason that somebody can't get out. And so those advances, including now we have continuation of that program through 2027, shows that there is an interest in this. And we also know that it has cost savings. Data from Money Follows the Person is incredibly helpful when we are talking about the dollars and cents of it all on the Hill, because it shows 20% per month per beneficiary savings for folks who move out of that facility-based care and into the community. Now, that doesn't mean we still are going to need that upfront investment. And there have been a lot of different, we know that a bill is going to be introduced next week that will be more of a catastrophic insurance-based model, the WISH Act that Representative Swazi has introduced in the past. It's far from perfect, but it's a step, and it does show that there is an interest in really addressing this problem, because you have 10,000 people turning 65 a day, and this is an issue that we aren't going to be able to wait too much longer, and the costs are showing up in so many different places.
Backing up to your comment about, I guess, your polling, that 95% say they want to age in place, and certainly there's lots of other polling out there that echoes that, AARP has done, for example. Whenever I see those polls, my first thought is, what I think people really are saying is, don't put me in a nursing home. But the second thought I always have about it is, what do we really mean when we use the phrase age in place? I think people hear it as, I want to stay in my home that I'm in now. And some probably do mean that, but it's not the only definition. Can you talk a little bit about definitions of aging in place?
Yeah, absolutely. I think that's a really important point, Mark, is that aging in place, and I can say this, I'm very lucky to still have 3 of my grandparents around in their 90s, and aging in place looks very different for all of them. And so for my one grandmother, it meant moving into a senior living community. It's not assisted living, it's just a subsidized housing community, which is a big issue that we have, as Ben highlighted, and is just access to affordable housing has to be met in tandem with services. So you have folks that might not want to be staying in their home that maybe they've owned for 40 years, but wants to move into and that can also help with things like loneliness and that sort of thing. So aging in place might look like something like that, which is why you need affordable housing units that are embedded in the community, where also people that are not disabled, not aging, are living with folks as well. It can also look like staying in your own homes and getting the ramps and other accessibility pieces that you might need. But Mark, as you pointed out in some of your initial comments, the reality is that doesn't happen without a lot of support. And frankly, like, that's something that my other 2 grandparents, hopefully they're not watching this, that they split their time between Florida and Wisconsin, and they just expect all of us to do what we have been doing, which is they have 16 grandchildren and 5 children, and we all do this kind of care conga line, because they're not eligible for Medicaid. But my grandma has Parkinson's, and if she falls couple years ago and needed back surgery, I went down there for 2 weeks. Those are the things that family members all over are doing, and it does come at a cost. Per the National Partnership for Women and Families, that cost is $1 trillion to the economy. Also, Mark, as you pointed out, it's about future earnings and your own retirement security. And so aging in place can look like a lot of different things physically, but it also looks a lot of different things support-wise. And until we have a system where anybody who needs care has options for care that's outside of their families. And also, my grandparents are very lucky that they have those families that can step up. That's just not the case for so many people, which is not a failure on those individuals or the families. It's just the reality. And so, aging in place can look a lot of different ways, but ultimately, what it requires is a system of supports. And that might only mean 5 hours a week, 10 hours a week, but that's not the system that we have set up right now.
And you know,
Yeah, that,
it's
go
also
ahead.
worth, I think it's worth noting too that there's another cost to people staying in their homes. It's one we don't want to think about, but it's a reality, which is we're facing a desperate shortage of direct care workers. It is much more efficient to provide care to people in communities, in closed communities like a senior living community, than it is to travel around the suburbs or into rural areas to provide care one person at a time. My wife was a hospice chaplain, and she spent some days literally more time in the car than she spent with her patients. So we have to think about the supply problem as well and how we're going to confront that. And if we're not going to pay the aides what we should, if they're not going to be a sufficient number of them, if we're going to have crazy immigration laws that are going to limit the number of aides that are available to work, we have to think about what the most efficient way to deliver care is. And sometimes that may not be in people's homes.
Yeah, absolutely. And that those are decisions that we shouldn't be having to make. But because the main funder for long-term care in this country is Medicaid, and Medicaid is also a workforce program. Medicaid pays 70%, the wages for 70% of direct care workers. And not well, not enough. That was why we saw 50 states taking up that short-term funding, and the vast majority of those states used it for workforce funding, for bonus payments, for retention payments, because we do have this huge need. You have a workforce where you have a 50% turnover rate. And it's not because that these folks are not committed to the work. It's because if you can make more money down the street at Costco or at a fast food restaurant than you can do doing this extremely emotionally and physically taxing work. So absolutely, we're not going to be able to have folks aging in place if there's not enough workers. And that also costs money because we have to invest the money to raise those wages above and making sure that those folks are having a family sustaining wage.
Mason, there's
Yeah,
every reason to go ahead.
I was just going to add, yeah, a well-designed independent living community, people are assisted living for that matter as well. Many people are much happier in those communities because they have friends, they have places they can go and do things, and with a low threshold to get there. You walk down the hall or you walk across the street to the community center where they have the cards and the whatever, and with all the other activities that you can do. People I talked to in the Netherlands they said, I thought the last 10, 20 years of my life was going to be sitting in front of a TV on the couch by myself because my husband passed away and I'm sitting there all day long watching TV. And now I'm in a senior community with 200 other people, and I have a lot of friends. I do gardening. I go to the town on the bus and et cetera, and get to go shopping or whatever. They have a life, because it's geared to anchoring you in the community. And I think a lot of people, it's not just a necessity to do that, or it's not, people actually enjoy that lifestyle if it's done well.
Yeah, I was going to ask a follow-up question to any of the panelists that might want to comment on this, going back to this question of the cost of care and labor force issues. If memory serves, the cost of long-term services has already been rising probably double the rate of inflation for years. And now looking at this expected crackdown on immigration, the labor supply is going to be tighter. So the cost of labor is probably going to go up in this segment of the economy. I think New York Times actually carried a story over the weekend making this point, and they discussed the care sector as well as some others. But there are probably some other inflationary factors too that when we think about the cost of these solutions, it's the cost is going to be escalating. I mean, anybody in the panel that like to talk about that challenge?
So here's the paradox. Nicole talked about this. We pay care workers on average about $17 an hour. It's not a living wage. Many of them are on Medicaid
Right.
themselves. The problem is that even at $17 an hour, many families can't afford that.
Hmm.
So we have this kind of complete market failure where the compensation to the people who do this work is insufficient, but it's still too much for the families who need them. So how
Right.
do you fix that problem? You can raise the wages and the working condition, improve the working conditions for the aides, but then you're going to have fewer families who can pay for them, or they have to bring them in for fewer hours. So it kind of goes back to what we said at the beginning. You've got to have more money in the system or it collapses. It doesn't work.
And find ways to
But
provide
that
care, but more efficiently.
Or find ways to deliver care more efficiently. Correct.
Go ahead, Ben.
Yeah, and that gets at the whole rationale for this research on on the Dutch system is because they are facing the exact same challenge, and they have found ways to do precisely that. I mean, you need quality jobs, and the Netherlands pays their care workers better than almost any other country in the OECD. So they don't achieve the universal coverage and person-centered aging by underpaying their workers. They pay, they do a good job on that. But what you do, the people who are providing the care, you want to pay them well so that the people they care for are also cared for and that there isn't inequity in the system. But you have to then make sure that fewer people end up needing long-term care. That's really the secret to it. And the people who do provide it get paid well, but fewer people overall need it. And you can do that by addressing social determinants, by getting upstream with good supportive housing solutions, reciprocal care, good use of technology, and a lot of other things that discussed in detail in the paper that bend the cost curve on that. The Netherlands determined about 10 years ago that if nothing else changed in their system without these reforms, which they've done, that by 2060, more than 1 in 3 workers in the entire Dutch economy would have worked in the health and long-term care sector in order to provide adequate care. And they said that's just it's not sustainable. That would undermine our GDP if everyone had to work in this one sector, or a third of our workers. And so that was a big driver for why they came up with more efficient ways of providing person-centered aging.
Narda, let me ask you a question that I think maybe pivots off of what we were just discussing. Scan's done a lot of work in the area of cross-sector collaboration, and I'm wondering if you could comment on the importance of that and where it might all be going. I'm wondering if there are opportunities there to get a handle on costs.
Yeah, thank you. And I know, Ben talked a lot in the paper about, the Netherlands working across all levels of government, there being a much more deliberate coordination across municipalities, et cetera, and coordination with those that deliver services, those that receive services, et cetera. And especially in this time where we're in, where, we have, as we've discussed, there's the Medicaid program, there's questions about what incremental things Medicare might cover, or programs offered through the Older Americans Act and what have you. And I think what we're really seeing is that as a result of there not being sort of a single responsible body, no one is responsible, particularly beyond the Medicaid population, which, by the way, those folks that have been talked about in terms of that forgotten middle, or those above the Medicaid threshold, but don't have necessarily the means to pay out of pocket, is expected to double in the next 10 years. So that's an issue that we're not seeing going away. But absent any major reform that would sort of pay for a social insurance program, what we've really seen is interest first in the state of California, but then also in other states across the country, red states, blue states, and even at the federal government, of bringing some of these different government agencies together that play different roles in the long-term care ecosystem, in service to doing a better job of braiding and blending funding streams, doing a better job of determining who is responsible for what, and making that process a little bit less complicated for the consumer themselves to navigate. So we started that work in California in 2019, and now more than half of states have some sort of multi-sector plan on aging, which is intended to bring folks together. And these are the types of changes that take a generation to see meaningful execution of, but there are also some interim benefits that we've seen. So, Nicole, for example, was talking about that one-time infusion that happened at the onset of COVID to support home and community-based services. Because California had already engaged in this multi-sector process, there were already the right people at the table to be able to quickly decide, what are we going to do with this funding? How are we going to get the dollars out the door so that relief could be provided more quickly? So, in addition to moving things a little bit more incrementally at present, which is just a little bit of where we are. There are other benefits in that it helps government agencies, it helps various stakeholders identify areas for consensus beyond necessarily just one big reform to start to move that needle. We are very excited about the interest that we're seeing across states. And again, regardless of whether it's a red or a blue state, there's interest in momentum. And we're hopeful that it'll continue to pick up.
I
And
do.
are those, go
Oh,
ahead.
sorry. I was just going to say, and I think the multi-sector and de-siloing of agencies and funding is incredibly important. And I just want to name, especially considering once a disability rights advocate, always a disability rights advocate, is that a lot of those might be called as a multi-sector plan on aging, but actually has a lot of disability overlap. And I think it's incredibly important that we name that as we're making these policy moves, because there's still 35 states that have state-funded intermediate care facilities. That's a lot of money that's going to long-term care facilities when, again, 95% of disabled people want to stay at home. So there are a lot of costs associated with all of this, but there is money in the system that is being wasted, if you ask the people that are actually in the settings.
100%.
If I could,
If I could,
yeah,
the other thing I want to say
right.
about just a little, not pivot back to workforce, but in response to some of the workforce pieces as well, recognizing, these multi-sector plans on aging are in no way, shape, or form positioned to solve the workforce crisis, particularly because there's no explicit dollars associated with these plans. However, what it has started to result in is just identifying other folks within the community that could provide more informal care supports, as in sort of volunteer capacities, or things like what Howard was talking about in terms of the village type community, where individuals are just more engaged and working collaboratively with their neighbors to look out for one another. And we know that also has downstream benefits, both for, again, the person receiving care, but for building community more broadly.
Narda,
Narda,
one of the things I wonder about is these multi-sector plans have been doing very well when the states have been flush, when they've had a lot of money. Um, Most of the federal money, the COVID-related money, has gone away. We now may be looking at a slowing economy. Are you concerned at all that these multi-sector plans are going to start to stumble a little bit because you're going to have state agencies that are going to be trying to hang on to whatever dollars they have and they don't want to share?
It's a great question, and we're only starting to sort of see some of this in practice. But I think one other sort of side benefit of the multi-sector plans on aging is that it does develop this really strong advocacy community, and as Nicole mentioned, both aging and disability, service providers, et cetera. So California, as you may know, is experiencing quite a shortfall, and because of the advocacy community and because of just the momentum that has been built to date, it's been very hard for the governor or the legislature to walk back from some of those commitments that they've made. So it's actually been a helpful tool politically. And these blueprints tend to be around 10-year-ish time frame for the blueprint. And so it's also not very politically palatable for, in a governor's campaign or a governor's race to say that this is something that's going to go away. It's, folks do want to hear that commitment to aging, just because universally we are seeing that population rapidly increasing.
and in a state like California, where the cost of housing is so high, that must be just a gargantuan part of the challenge.
It is, and that is where a lot of that breeding and blending work is happening right now. But I think California's housing affordability challenges certainly go beyond just the older adult
Oh, for
community,
sure.
and I know that there are there's policy work being done in that space, but even more reason why the housing folks and the aging folks and the long-term care folks and the Medicaid folks should be working in concert with one another.
Ben, were you going to comment?
Yeah, Mark, one of the points in the paper about the Dutch system was that these reforms were designed by health economists in the Netherlands, and they were designed to get the incentives right, to incentivize strategic investments that would improve the system overall and lower costs overall over the long term. Very smart health economists who did this work. thoughtfully. And one of the advantages of a universal social insurance program like WACARES, or if this were done through Medicare, is that if you have a payer that is incentivized to lower its claim cost over the long term, it can incentivize investments in the long-term care system that would address, that would provide upstream intervention, allow people to age in the community more, with under the assumption that this would save claims costs down the road and then pay for it. And right now we have a lot of different payers, but they're not incentivized to make strategic investments. So I think something that we need to look for going forward.
So I think it's actually worse than that, right? So Ben, you talked a little bit in the paper about the wrong pocket problem in the Netherlands. We have a terrible wrong pocket problem, and it really goes back to the creation of Medicare and Medicaid, right? So if I'm a governor and somebody says, Narda and Nicole says, we would like you to spend more money on Medicaid so you can provide better services. The governor says, yeah, great. That's going to save on medical costs, but I'm not going to benefit from that. The federal government's going to benefit from that from Medicare. So what's in it for me to spend my budget so that Medicare can save money? And as long
And
as
there's no shared savings vehicle anymore, right, Howard?
and
So you
there's
can't
no
get
share
shared savings
exactly.
in a
That's
waiver.
exactly right. So
Right.
so the Netherlands figured this out, and maybe Ben, you could talk a little bit about how that happened, and maybe there's a lesson here for us.
Well, simply by having, basically, these are all public sector and nonprofit entities that come together every year to plan, like Narda was saying, they plan the system together collaboratively, and they all have an interest in building a better system because it's either government or nonprofit. And so they plan together. Obviously, the insurance companies are part of the government, and they are nonprofit, and they are trying to lower the cost over the long term. And so they're incentivized to work together to make those kinds of investments.
Let me just remind the audience that if you have questions for the panel, please pop those into the Q&A box at the bottom of the Zoom screen. Ben, we weren't going to spend time on this call talking much about walk hairs, but I think it might be useful to do that for a minute because I don't know that everybody in our audience really is familiar. Maybe you could just give a quick description of the program you're directing in Washington State and your day job, and then maybe reflect a little bit about that in light of the research paper, and how do you connect the dots there?
Sure. WACARES is the first public long-term care insurance program in the United States. I think several other states are likely to follow us in the coming years. Several states are looking at similar models. New York, California, Massachusetts, and others are looking at similar models. And what we do is simply cover everyone, kind of like Medicare hospital insurance, where everyone pays in out of every paycheck, and then when they need care later in life, they have access to. It's a small benefit. It's $36,500. It's adjusted for inflation over time. We're also looking this year. We could very well see the enactment of a supplemental private statutory framework, which would create something like Medicare supplemental for WACARES, where private insurance companies could step in and extend the benefit to $100,000 or $200,000 for people who want more insurance coverage in this area. They could buy, it would be cheaper than it is today because WACARES covers the first tranche of risk, which makes it cheaper for the long-term care companies to price supplemental policies. Together, I think this is going to invest the kind of money into our system, into our long-term care infrastructure that will give us the ability to start to redesign it and make it work better for our consumers.
Yeah, and that public-private side of it that you've been working on is really interesting. And I know, Howard, that's something you've looked at in some of your previous research and policy proposals and we were talking just before the call about this, that it's always really amazed me that there wasn't more interest from the private sector long-term care insurance companies in putting something together that rides on the top of a public platform, given that we have a really dramatic example of success from a private company standpoint in Medicare. I mean, I and many others have criticisms of the privatization of Medicare, but there you have it. That's where we live. And it's been a huge success for the private insurance sector. Howard, can you talk a little bit about that and what you think the potential is? Well, maybe you can talk about it both at the state level and if there's something at the national level you want to discuss.
Yeah, it's interesting. So let me back up just a little bit. So there's two basic models, there's three really basic models of public long-term care coverage. There's the front end coverage that Ben runs in Washington State. It pays the first $36,500 and then you're on your own. There's the catastrophic benefit that this long-term care collaborative designed, and it's what the Tom Swazi bill would do. And the idea is you would be responsible for paying for the first couple of years, and then the government would pay if you have a true catastrophic need. And then there's the Dutch system, which is a fully comprehensive system, which seems probably beyond the political reality of the United States. So you have to decide, do you do a front-end benefit or do you do a catastrophic benefit? The interesting thing is when the actuaries and the modelers look at this, the cost of something like the Walk Cares program and the cost of something like a public catastrophic program are almost exactly the same. It's a payroll tax of about 0.5%, 0.6%. The reason is because the catastrophic program covers a relatively few people for a big expense, and the front end program covers a lot of people for a limited expense. But it turns out to be the same money. Now, if you look at this from the perspective of private insurers, what they are terrified about the most is what they call the tail risk. It is that true catastrophic care, mostly for people with dementia. You sell them a lifetime policy and it breaks the bank. That's what put a lot of long-term care companies out of business. Um, they are looking, for a long time, they thought of the public insurance model as competition. And in the last couple of years, they're started to change their minds. At least a few of the carriers are starting to change their minds, and they see it, as we've been suggesting, not as competition, but as an opportunity, as a market opportunity. And the idea would be that you as a consumer are going to need to pay for some of your care. And it may be after that first 36,000 as in Washington State, or it may be that front end, if you have a public catastrophic program like the Swazi bill. You need to pay for some of that. There's only a couple of ways you can do it. You can use home equity, you can do savings, which Americans don't have, or you can buy insurance. And the insurance companies are saying, we could maybe figure out a way to sell a product here that would supplement or complement the public program. So it's a real change in attitude. And I think we may see over the next couple of years, the insurance companies and the government and consumer groups and providers kind of getting together and saying, this is really in all of our interest. So there's hope where there wasn't a few years ago.
I
So
think
these two models, Nicole, let me just interject one question, then I'll pivot to you. These two models of funding the catastrophic versus the base level of care, Howard, as you say, they cost out about the same, but it seems to me the marketing challenges are vastly different. Like you're trying to sell a base level of coverage that becomes kind of universal. I'm skeptical about that given the experience of selling long-term care insurance in the United States.
So if the long-term care insurance companies have to provide only a limited amount of care, they can sell it for a lot less money than if they're trying to sell a product that's covering many years of care. So the main reason people don't buy long-term care insurance is it's too expensive. So if they could sell it at a lower cost, they might be able to get more buyers. And the trick, and Ben can talk about this because he's been so immersed in it for the last couple of years. The trick to any insurance program like this is it has to have a lot of people in it. You have to have
Right.
a really big risk pool.
yeah.
That's why you make a public program universal, is so you have this huge risk pool and the per person cost is relatively low. And that's what's done in private long-term care insurance is the risk pool has been very narrow. It's been limited to people, for the most part, who think they need the care.
But in addition to the cost, isn't there this kind of psychological challenge that, people just don't want to think about these issues? It's the old, I don't want to think about my future self business.
Totally.
It's
It's a
tough.
it's a it's a it's a huge problem, but you can address the problem. You use the Medicare example. People realize that Medicare Part B, Part A and Part B provide only limited benefits. And they understand that if they really want to have better benefits, better insurance, they have to go buy a Medigap policy or a Medicare supplemental policy. It's the same thing with long-term care. In Washington State, and Ben can talk about this, I suspect that people have come to understand that $36,500 is not going to pay for all their long-term care. That awareness is going to make them more interested in looking for some other solution like a long-term care insurance policy.
Yeah. Ben, do you want to talk about that? And then I want to go to Nicole for a sec.
Yeah, I would agree with Howard. I think it's an amuse-bouche, it gets people's appetite whetted, and then they want more because they become a cognizant, something that Ajahn Poo talks about a lot, which is that, a program like Walker's transforms the paradigm from care being a private individual responsibility to being a shared communal responsibility. And once you have done that paradigm shift, it's easier to talk about, it's easier for people to be open to buying supplemental private insurance. I think one of the psychological challenges to your point, Mark, about the back end catastrophic coverage model is simply that, I already hear from people when I talk to people in Washington State in the community about walk cares. There's always someone in if there are 30 people in a room, there's always a couple people who ask, well, what if I don't need long-term care? Do I get my money back? And you have to explain that no, you're paying in less than you would otherwise because it's not a savings account, it's insurance, and only 7 out of 10 people end up needing long-term care. But with a catastrophic model, you're only 3 in 10, or 2 or 3, maybe 2 in 10 would end up benefiting. So 8 in 10 people would be paying in and getting nothing back. I think in a democracy, that's a hard thing for people. I don't know of any, no country has ever done that model to my knowledge. And I think politically, the front end coverage is a lot easier to get over the finish line than a catastrophic model.
Interesting. And Nicole, you wanted to comment on this area, I think.
Yeah, I just wanted to name that, private insurance for long-term care, there was a bit of a market for it, and then the market share has significantly dropped. And so and to Howard's point, that's likely because of the risk pool and everything else. But having faith in insurance companies to come up with a good model is something that I would hesitate around. And I do think that ultimately, though, there should be something where we're coming together, because we know from, again, some polling that we've done that 93% of Americans believe very strongly in their incorrect belief that Medicare covers long-term care. 66% of those folks are very confident in their belief that it does. And so folks aren't realizing that they're wrong until they're at a point of crisis or catastrophe. So there needs to be something. I just need to publicly share my skepticism in the private market, especially given, we know that 75% of Medicaid is overseen by private insurance via managed care. And that hasn't gone to a lot of benefit outside of the benefit of private insurers' bottom lines. And so I do think that we do need some sort of public-private solution. I think the WISH Act is an interesting idea, although again, you're only covering people when they're at a point where it's much cheaper to meet folks where they are much before they need it.
Yeah. And the difficulty of raising taxes to do these things, I think, is probably beyond debate. I mean, you've succeeded in doing it in Washington State, Ben, but Howard's comments earlier about how hard this is to do at the national level, I don't think is even debatable. But a point I would raise about that is that to me is an example of political dysfunction, not public opinion. The Academy's recent study on polling on what people would prefer as solutions to the looming shortfall in Social Security's trust funds underscores that you ask the public what they'd like to do, and they say, yeah, raise my taxes. It's like, hello, so I mean that runs against what the assumptions are and what drives politics in Washington. And I wonder if the same might not be true in this area. I remember back during the Great Recession, we had at one point a payroll tax holiday that was put in place for, I forget if it was a year or 2 years. And I remember there was a poll done after the tax was reinstated. I think Dean Baker did this, the economist, that most people weren't aware that the tax holiday in the first place, and they weren't aware that the tax went back on. People are not focused on, looking at their pay stubs and seeing what's being taken out. My point being, a long-winded way of saying, I bet you anything that if we were to somehow find a way to add a layer of FICA tax, most people wouldn't even blink at it.
But Mark, I think
No,
keep in mind Nicole's point, though. I think it's really, really important. If people think that Medicare is already paying for this, they say, hey, I'm already paying my taxes for this.
Right.
What are you talking about? And it's going to take a real public education process, which Ben did in Washington State, to help people understand that, well, no, Medicare isn't paying for it.
Yeah, yeah, no doubt. Ben, were you going to
Another
say
important,
something?
yeah, another important thing to keep in mind about the front end versus back end choice is pre-existing conditions people are excluded if they have pre-existing conditions. So people with disabilities, for example, would benefit from a front end program if they qualify by working in our state. Half the people with disabilities do work and qualify. Whereas if it's a back end catastrophic program, if you have any pre-existing conditions, and up to 30 or 40% of people do, depending on the research, they wouldn't be able to access private insurance to before they went on the catastrophic. So I know a lot of times people say that the private insurance could fill the gap between the status quo and then when the catastrophic kicks in, but that's only true if you pass the underwriting.
Well, that's an example of the kind of complexities that kick in these kind of markets, right? Like if you look at Medicare, you got the same kinds of issues running around in Medigap. Some states have ongoing continuous enrollment, guaranteed issue, so-called. It's only three or four. If not, you need to know what your guaranteed issue window is at the point of initial sign up for Part B, and on and on and on. It's just there's so much complexity there that people just don't understand. That's one of the concerns I think about
Yeah.
doing this with private solution.
If I may ask actually a question to any of the panelists, but I think Ben in particular, just given the work that you've been doing so recently on the ground in terms of understanding where folks are, what messaging resonates, what doesn't with different constituents and stakeholders, and also recognizing that when we think about private options, just also the general sentiment of mistrust, which is increasing around the insurance community at large, and that's not just health insurance, it's also, homeowners insurance and other types of insurance products. And I'm just curious, Ben or others, whether you see that as a potential risk in terms of thinking about that messaging of private public partnership and or how to mitigate some of those very real, obviously very
Yeah.
salient concerns.
Absolutely. I mean, I think that can be overcome by the public and private sector working together and having a good statutory framework around the supplemental, so that it isn't. So you have strong consumer protections in the supplemental private market anchored in law. That's what we've done in Washington State. If the bill passes this year, it's under consideration this year. Then the law that's in front of the legislature would have strong consumer protections. And if that were enacted, then we could put on our website, here's WalkCares, here's how it works, and if you want to know more about supplemental private coverage, here's some companies offering it, here's how it works. And we could go out into the community with those carriers and talk about it. But you need to have a well-structured market with strong consumer protections in order to do that. But there's no future in this without public and private sector working together. That's really the only path forward, because long-term care is so expensive that public insurance can't do it alone, nor can private insurance.
And there is, Ben pointed this out, there is this weird thing about long-term care insurance. This idea that, what if I die before I need the insurance? I've wasted my money.
Right.
And nobody says, I bought homeowners insurance and damn, my house didn't burn down. I'm really mad. But they do it with long-term care insurance. It's a real interesting psychological issue that we've got to figure out some way to overcome.
Yeah, although I mean the health insurance comparisons maybe are closer, the need to carry health insurance and remember the whole thing over mandatory coverage in the ACA, et cetera. But yeah, well, I've thought about the same thing as like this is what the point is of insurance. It's
Right.
like
Yeah.
maybe that's another education cafe that's needed out there. I wanted to leave a little time for some questions from people who are attending the webinar. We've touched on the WISH Act a couple times, and somebody in the audience wanted to know more about that. And if one of the panelists would like to just describe a little bit more what that's about.
So I'll jump in and somebody else can supplement it. I mean, it is a public catastrophic long-term care insurance program. People would be responsible for paying for the first period of time, and that period of time would depend on how much money they made. And then the public catastrophic program would kick in. It would be universal, so everybody would participate. Um, the original WISH Act was funded with a payroll tax. The new version does not include a funding mechanism because it's so controversial. One of the very interesting things about this, though, is that Tom Suozzi, who's sort of a moderate Democrat from New York, was kind of on his own about this the first time around, but he's got a Republican co-sponsor this time. And in this day and age, getting a bipartisan bill about anything is really unusual. So again, that's a little bit of a sense of optimism. Um, and Ben can disagree with me, but I do think that there's a real benefit to having a federal program here. Washington has struggled with a number of issues because it's a state program. What do you do if somebody lives in one state and works in a different state? What do you do if they pay taxes in one state and then they move to another state? There's all these issues that you have to deal with when you have programs that are state by state, and that would be addressed if you had a public program, a public federal program. So I think there are real benefits to doing it on a federal basis, but realistically, I think this is going to happen in states first.
I don't disagree,
that's,
Howard, at all.
yeah, I mean, it brings to mind what's been going on with state level retirement savings programs, which I think have spread to maybe 15 states now, something like that. Hasn't been taken up at the federal level. An attempt's been made. Another question that I wanted to bring up from the audience is that this references the village model, which is thought to be pretty valuable. What are the chances for greater governmental support for those sorts of things, which typically are done by nonprofits?
I will name, and just also on the Wish Act, just want to say, and I do think that they've shifted this in this version, although I haven't read it yet. But something that's important and that Washington Cares did is that it's important to, again, make sure that both aging and disability are covered. So just naming that that was something that we are hoping to see in this version. So hopefully that is the case with this version of the Wish Act. And on that same vein with the village model, that is something that for a lot of older adults is something that is desirable, but it's for folks with disabilities, it's incredibly important to make sure that we're also making sure that those types of models are integrated. So we obviously want to fight against loneliness for aging adults and for disabled people. And so there could be governmental support for programs like the villages, if those types of settings are integrated. Currently, there are very clear rules from the Center for Medicare and Medicaid Services about the types of settings that can receive, for example, Medicaid funding, and they do have to have some level of integration aligned with other people in your community who don't have a disability. I'm saying that intentionally because rural settings are different. Other communities have different quote unquote norms. And so it's not to say that if you're in a setting where everything's happening in one community center because that's the one place in town, that can be integrated. So I just want to say that there's always nuances, but it will be really important that those types of models do have people without disabilities, people who aren't aging also to come in and provide that sort of non-paid support that can happen from community-based settings.
And to your knowledge, are villages integrating services for disabled people at this point to any great extent?
There are some family members in the disability community who are building villages. I have a brother with autism. It's like very popular in the autism community. But I would say that you can do it right, but when it's not right is when it looks like a new institution where it's only people with disabilities living with staff and not having outside factors coming in.
I see.
And I would say,
I just want to reinforce on top of what Nicole's saying too, is that, there's also been a lot of sort of data and evidence demonstrating that, certain, racial ethnic minorities are also generally have been left out of the village model. So that I think is another really important consideration as we think about any sort of like community-based model moving forward. And in terms of government coming in to help support and funding, right now there isn't a very robust longitudinal sort of evidence base around the impact of the cost, implications of or cost savings associated with living in the village model and rehospitalizations and things of that nature. So I know that there's a lot of interest in getting more evidence and data in that vein, but I do think that that's going to be right now it's anecdotal and
yeah.
Let me be a little contrarian about this. I actually think that federal money for villages is not a good idea. And here's why. I think that the great benefit to villages is that they are hyper local and they really, when they work well, they're designed for the community that they're in. And if you get federal money, you're going to get strings. You're going to get federal regulations. And to just put it kind of as crudely as I can think of, I don't know if I want Elon Musk telling me what I should do in my village. Um, I understand that they need resources, but I'm not really sure that getting federal money is the way to do it. And the last thing is, you start to live on federal money and it gets taken away, and then what
Right.
happens?
Yeah. And just to
Yeah,
put a footnote
I
on
would
this
agree.
whole thing, I did, Ran, one sec. I just wanted to put a footnote on this because whenever I talk about the villages, somebody inevitably thinks I'm talking about the villages in Florida, which is not what we're talking about here. The famous villages. This is, this very decentralized, community-based grassroots effort.
Resident care, yeah, resident,
Yeah.
these are people caring
Just
for
to
each
be
other,
clear,
right? And they're,
just to be clear, go ahead, Ben. What were you going to say?
yeah, I mean, I would take a similar take as Howard, slightly different in that I don't think so. In the Netherlands, they have something similar. I talk about it in the paper. It's called resident care cooperatives, where you pay in, $15 a month, and then you're a member, and then you care for your neighbors, and then when you're older, they care for you. It's a great model. It's more expansive than the villages movement in our country. But I think these things could be part of multi-sector planning and part of civil societal initiatives. I don't think the government has to be doing everything. Not everything has to be government run. It can, and as Howard said, it often works better if it remains a grassroots movement. But I do think it makes sense to have a holistic approach to long-term care where resident care cooperatives members of those are sitting at the table with other community organizations that are trying to plan the long-term care system and saying, we play we're one piece of the puzzle. There are other pieces. Let's try to get these pieces to fit together in an efficient way. And so multi-sector planning can involve some things that are government funded and some things that aren't.
Mhm. Yeah. Looking at some of the questions, we've got a couple minutes left, and I wanted to get to a couple more questions. One question, this is, I think, an interesting one. As usual, the Dutch are way ahead of us when it comes to long-term support and services. While there clearly are financial and incentive alignment issues, person-centered pre-acute care is also a public health issue. How can public health strategies and emerging technologies contribute to the solution? Who would like to talk about that?
Well, Ben, you had some interesting examples of technology in the Netherlands.
Yeah, I mean, part of what they do, there's this organization called Buurtzorg, which is a nonprofit health insurance organization there that is the most widely used home care agency in the Netherlands, and they try to anchor the person in the community. Could we I
Yeah,
forgot the question.
the
Sorry.
core of the
Could you
question was how can public health strategies and emerging technologies
Right.
contribute to solutions?
Right. So part of what they do is because they're integrating home healthcare with other healthcare, they try to make sure that the person who's trying to stay in the community has a primary care physician nearby, a gerontologist nearby, a physical therapist nearby, and make sure that they can get to those supports so that they can actually age in their safely and healthily in their neighborhood in a holistic way. And again, the kitchen table conversation that I mentioned earlier, which municipalities do as part of the social care, to make sure that people have the supports around them in close proximity to where they live. So that's the kind of thing that can save a lot of money over the long term and allow people to, as you were saying, Mark, aging in place can either be sitting on your couch in front of the TV or it can be actually having a socially anchored life in the community.
Yeah.
So there's
And
an interesting debate in the long-term care world about, you know, is aging a public health problem?
hmm,
And some people will tell you, you don't want to put it in the public health world because you're just going to medicalize everything. And other people will say, well, no, social determinants are really important, and this is a public health issue, and you need to confront it. So it's an interesting debate, and I think it's sort of gone unresolved so far, but sort of good to have the conversation.
Yeah.
yeah.
And I think that that's a real that's something too where, I've talked about disability and aging needing to go more hand in hand. And I think with the disability community, we've had more of those conversations and a real decided shift away from the medical model of disability to a social model of disability. And the same should be true about aging. We shouldn't just be concerned about the medical in acute health of older adults. We need to be thinking about those social determinants of health, all of the different ways that we keep people healthy that is actually about social connection and is actually about community. So I do think I agree that we have to be conscientious as we're having these conversations. And I think that there should be a big push as we're trying to solve the long-term care crisis in this country and looking at models like the Dutch model to really think about how are we integrating the whole person? How are we thinking about the all of the needs of that person and not just their physical well-being?
And last question, then I'm going to turn things back over to Rebecca to close things out. This goes back to the discussion earlier about pre-existing conditions and the difficulty of kind of during your working years when you're younger, kind of thinking about and predicting a possible long-term care need. And I know just from my own reporting, others in this call can comment with more expertise, I'm sure, that when you really dig into it and look at what does the actual risk look like, it's very complicated. And, we always hear these statistics thrown out that half of us will need X, Y, and Z, or, most of us will need X, Y, and Z. But when you really get underneath the hood on that, it's much more complex than that. So I guess this goes maybe, Howard, back to the question of educating people how to think about risk.
No, I think that's right. So we know that to go to those numbers, we know that 70% of people over 65 are going to need some long-term care before they die, and more than half of them are going to need paid long-term care before they die. Uh, but who are you? Which of those are you? And we also know that dementia in all of its forms is probably the single most important cause, especially a long duration long-term care. Um, and we just don't know nearly enough about dementia to be able to really fully understand it. So yeah, it's hard. It's a risk, and it's a risk that I think the takeaway from this conversation is it's a risk that too many Americans and the government are willing to take without preparing for it. And I think that's really the challenge here.
Yeah, it goes back to your home
And
insurance question. It's like, what is my risk of my house burning down? It's like,
Yeah.
Ben, Ben, why don't you close it off, and then we're gonna go back to
yeah,
Rebecca to close this off here.
sure. One of the things that, we in when I do community outreach, there's always at least one John Wayne in the audience, right? Who's like, I don't need this. And you can just see it on their faces sometimes. Usually most of the women in the audience understand it because they've been caregivers. Sometimes middle-aged men haven't. And but what I tell them, and which is true, is that even if you think you're a tough guy or a tough person, if it's a woman, and you're going to get, even if you need, a lot of people say, well, if I end up needing care, then I'll just tough it out, But the reality is that when you're that tough person who turns 85 and you get dementia, you don't tough it out. What happens is your daughters or your sons quit their jobs and take care of you. That's what happens. So you're not toughing it out. You're just relying on other people, as Nicole was alluding to before. You're just relying on other people to sacrifice their economic security to care for you. So we're not islands, we all are part of families and part of communities. And if we don't prepare for this risk, then the people, our loved ones, are going to be the ones who pay the price.
Yeah. Well, Ben, thank you so much for this very provocative and informative paper and discussion. And Nicole, Howard, and Narda, thank you so much for participating in the panel. And we're at our time limit, so I want to turn it back over to Rebecca.
Oh, big thanks, Mark and Ben and Nicole and Howard and Narda. What an incredibly timely and thought-provoking conversation. And I feel like we could have given you guys 3-4 hours, and probably you still wouldn't have covered everything that needed to be talked about today. But just
Okay, well, let's just go for another couple hours.
yeah, there you go, Mark. There's your extension, right? So what I will say is that we look forward to many more conversations on this topic with these wonderful, brilliant folks and other Academy members and allies allies and folks across the community. I'll put in a quick plug for some of the work that several of these folks all contributed to years ago. This is the Academy Study Panel on Designing Universal Family Care, with big thanks to Caring Across Generations for being a partner on that, and Ben Veghte for having really contributed tremendously. So obviously a long arc, and one that the Academy looks forward to continuing to invest in and to hold space for. And please stay tuned for lots of future conversations on this topic here and with our partners. And with that, just want to send a lot of good energy out into the spaces that folks are moving in, where a lot of these timely conversations, including many of the defensive conversations, are happening as well, while we continue to think about like to build the system that we need. So with that, big thanks to everyone, and I hope everyone has as good a day as possible. And please join us for future Academy conversations on this and other topics. Thanks, everyone.